Another way to look at the purpose of a platelet's life in a linear, sequential, logical order of events is that the first thing a platelet does when it grows up to play its role in coagulation is to adhere to the extracellular matrix by virtue of the fact that the endothelial cell has been disrupted. There is then secretion of ADP and thromboxane A2 from the granules of the platelet, and this exposes phospholipid complexes which now enable the platelet to express tissue factor. And as you know, tissue factor triggers off the extrinsic coagulation cascade, ultimately resulting in the primary plug of aggregated platelets becoming the secondary plug by virtue of the fact that this is now being strengthened by fibrin. So that's how you go from platelet to blood clot. And we cannot escape the classical coagulation cascade. So let's talk about it. If you remember, there's an intrinsic and extrinsic pathway. The extrinsic pathway is much more direct and much more powerful. The extrinsic has a lot more steps, starting out with factor 12. And it's also called the contact pathway. The extrinsic pathway is called the tissue factor pathway. And it's a series of proenzymes being converted into enzymes by virtue of the fact that their predecessors have become enzymes, which convert the next generation of proenzymes into enzymes. The ultimate result, or the penultimate result, which means the second to the last result, is a conversion of prothrombin, which is factor 2, into thrombin, which is factor 2A. And finally, thrombin then ultimately changes fibrinogen, which is factor 1, fibrin, which is factor 1A. There's a whole bunch of cofactors. Calcium is one. Phospholipids are essential from platelet membranes. And there's a whole bunch of vitamin K dependent factors made in the liver, like 2, 7, 9, and 10, which you just remember rotely if you can't remember it any other way. And other proteins or factors like protein S, protein C, protein Z, primarily acting as anti-coagulants or checks on this whole cascade. And you know you're going to get the chart now, and we're going to see it again as well, and again somewhere else along the line. And you know, at some point in time, you're just going to have to know this. So let's know it now. And there might be better charts, but this is my favorite one. Your intrinsic pathway starts out when there's damaged surface, and therefore factor 12 goes to activated factor 12, and then activated factor 12 activates factor 11 into activated factor 11, and then activated factor 11 then converts factor 9 into activated factor 9, which, by the way, when combined with factor or activated factor 8, then finally converts factor 10 into factor 10A. And if you think we're getting towards the end, we are, because then factor A converts prothrombin into thrombin, and then thrombin converts fibrinogen into fibrin. And of course, fibrin can then become cross-linked. That's the complicated pathway. You should remember it. That's the intrinsic. The extrinsic factor pathway. The extrinsic pathway is initiated by tissue factor, which is more direct and more powerful. And tissue factor, we said was made by platelets, endothelial cells, traumatized tissue. So in the extrinsic pathway, factor 7 is converted into factor 7A, activated. And that has a direct effect now on factor 10 again to convert it to factor 10A, rather than going to 3 more steps like we saw here on the intrinsic pathway. If you look at the red arrows, these are all areas which act as a check on coagulation. So when you hear that protein C is an anticoagulant, you know it's going to have some effect on the conversion of factor 5 to factor 5A and factor 8 to factor 8A here in the intrinsic side. You know antithrombin, sometimes called antithrombin 3, has an effect on activating factor 10 as well as a direct effect preventing the formation of thrombin. If TFPI, tissue factor pathway inactivator, has its main effect on the conversion of factor 7 to activated factor 7. I don't think there's any way to make this chart fun or easy. I guarantee you should really know all the main players. There's a lot more. It could have been a lot harder. We'll come back to it again. Let's also try to make coagulation testing as easy as we can as well. In the old days, we called something PTT and PT. And PTT was generally a test to measure the intrinsic pathway, and PT was the extrinsic. And because the intrinsic pathway is the thing that needed measured for patients on heparin therapy, you got a PTT test for patients on heparin or intravenous anticoagulation. Now they call it APTT for activated. The PT is now called INR, unfortunately. That's the same concept as the prothrombin time, and that measures the extrinsic. Make a long story short, you got patients on heparin, you get yourself a PTT, partial thromboplastin time activated, APPT, APTT. Patients on Coumadin, oral anticoagulants, you measure the extrinsic system, and you measure their normalized prothrombin time, which is called INR. Another really good general and often screening test for coagulations, everybody gets it anyway in the hospital, is just to remember the platelets. And the platelet count is normally about 150 to 400,000. It varies. And if you have a bleeding time, which is normally from 2 to 9 minutes, that's a test of platelet number and function. If you have a normal number of platelets but an abnormal bleeding time, it means your platelets probably aren't working too well. And you know what this 2 to 9 minutes is. It means how long you could keep blotting blood from a small cut. And if you could still blots after 9 minutes, it's an elevated bleeding time. You can also measure the end product, or the second to the last end product of coagulation, fibrinogen. That can be consumed in a lot of hemorrhagic processes. And remember, if you have to, you could measure almost just about any one of those factors that we talked about if you suspected a specific factor assay. In clinical medicine, you're really going to be using your APTT, your INR, your platelet count, and your bleeding time for most common coagulation tests. Okay. Let's open the door to thrombosis and then deal with it in the next 10 minutes. Let's talk about the pathogenesis of thrombosis, the role of endothelial injury, the role of alterations in blood flow, the role of hypercoagulability, what blood clots look like, their fate, clinical correlations, and venous versus arterial blood clots. And we'll deal with that next. And I thank you very much for now.